Everyone. It's nice to see you here. Welcome and thank you for joining us today. We have a lot on the agenda and we have some fantastic speakers and fabulous questions from the audience. So let's start right away. I'm Harriet Kunishi, the commissioning editor for the open access journal Oxford Open Immunology, which is hosting today's event. And before we begin, I'll just go through some quick housekeeping points with you. You can participate in the ongoing Twitter conversation starting now by searching hashtag OxOpen long COVID, and you can see that in the lower left-hand corner of the slide here. And you can also use the chat tab in the upper right-hand corner of your screen to interact with other audience members. The Q&A tab is located next to the chat tab. And later, once the question and answer session begins, we'll list here the selected questions for the speakers. Note that this session is being recorded, including the question and answer time. And for closed captions, to turn them on, you should click on the little CC button on the upper right-hand area of your screen. And finally, we're all dialing in from different countries, so please bear with us if there are any technical hiccups. And now I'll hand it over to our journal's editor-in-chief, Professor Danny Altmann. Danny, over to you.
Hello. So I'm speaking, I think, through my iPhone. Are you hearing me okay? Somebody nod or say yes. Are you hearing me? Nod or say yes.
My apologies for this technical error. Danny, I'm sorry, we can't really hear you. So
Right.
Right. I'm not sure why, but there seems to be a disruption to the microphone.
And if I speak, hang on. If I speak through the MacBook, is that any good? At the moment,
This is better. This is better. Let's try that. So I'm going to go off stage now.
Any good now?
Yes, I think it's better now.
Okay, so sorry for the glitch. So welcome to this Oxford Open Immunology discussion on long COVID, an Oxford Open conversation with leading experts, and they really are leading experts. I was so excited to be able to get the people you can see here on the screen on board. So this is a discussion with a diverse audience of and people who have been inundated, responders of people registering to take part in this event. Broadly, people who we invited to lead this discussion are Akiko,
sorry,
COVID and
Danny, I'm sorry. It's very hard to hear what you're saying.
Do you want you or Rhiannon to take over and say it, and I'll try and see if I can get on later?
Yeah, sure. I'll start with brief introductions, and if you have any notes, you can just send them to me by email. But yeah.
Harriet, sorry
Yes,
to interrupt.
yeah.
I've just turned off Danny's camera, and so perhaps we could just try again for 30 seconds, and if not, then I suggest yes, let's continue.
Okay.
So at the moment I'm muted. Sorry, I'm muted on the webinar on the MacBook as well. Is that correct? So at the moment I'm only going through the iPhone.
Hi, Danny. We can hear you absolutely fine now. I've turned your camera off, so if you continue, then we can get going. Thank you.
Yeah. So we're okay like this. So I'm so sorry to be so disruptive. So what I was saying before I started breaking up is how excited I was to be able to get really such a stellar cast to have what I think will be quite a sort of novel conversation about where we are on long COVID, because we've got a kind of range of expertise really across Akiko Iwasaki, who I think of as a really leading figure both on COVID and on mechanisms and where we're headed in trying to understand long COVID, and Liz Whittaker, an absolute leader in COVID and long COVID in children, and Judith Brookfield, who's kind of my go-to person for long COVID on the ground and how it looks in the long COVID clinics and in clinical practice. So if I could have the next slide, please. Yeah, so what we'll do is we'll have a few minutes on immunopathogenesis by Akiko and how does COVID and long COVID look in children from Liz, and a sort of expert view on care pathways and trials, which I know is a source of immense interest to a lot of people watching and listening, from Judith. And then we've lined up a fair amount of time for questions and answers. And if I could have the next slide. Next slide. Hello. Next slide. Okay, so yeah, so
Okay, so if I can just jump in here, we have a call for papers on long COVID autoimmune disease sequelae of SARS-CoV-2 infection. And so we're just pleased to invite anyone here who might have something new and interesting to say about this subject. And we're very eager to kind of add to our existing collection, which has some of the very interesting papers in the field. So we really look forward to kind of increasing the numbers of papers in this area and adding to an exciting collection that we have already. So thanks. Okay, so without much further ado, shall we move ahead to our great speaker, Professor Akiko Iwasaki, and she's the Sterling Professor of Immunobiology and Molecular, Cellular, and Developmental Biology at Yale University. And she's also the investigator of the Howard Hughes Medical Institute in Maryland. So Akiko, thank you so much.
Thank you so much, Harriet, for the introduction. And I'm sorry, Danny, we couldn't hear much of what you said, but I got the spirit of excitement. Hopefully you can hear me. My name is Akiko Iwasaki. I'm an immunologist at Yale. I've been studying COVID and more recently long COVID. And I'd like to share with you some of the insights that we're getting and also speak about the potential mechanisms. So before I get into long COVID, I'd like to remind everyone that there are many other unexplained post-acute infection syndromes that are known to occur after encounter with many distinct viruses and bacterial and parasitic pathogens, some of which are listed here. This is a review that I was fortunate to co-author with Jan Chotka, who himself has an ME/CFS disease and has done a lot of great research in this area. But you can see that SARS-CoV-2 joins a long list of other viruses and other pathogens that can cause a sort of long-term symptoms. Much of it is debilitating, and must have a common sort of trigger that converge on a very similar type of syndrome after all. So we're very interested in understanding how many different pathogens can converge to develop a similar kind of symptom. So diving into the long COVID pathogenesis, there are a number of hypotheses, which I've listed only 4 of them here, but these are the major ones that we are pursuing. First hypothesis is that there might be a viral reservoir or viral associated pathogen associated molecular patterns such as RNA that persist in the host. When that happens, you can have activation of adaptive immune cells if there's antigens there, or innate immune cells if there are viral RNA present, and that can cause lingering symptoms if they're not removed properly. I've only listed a handful of papers on the left, but there are over 100 different papers already coming out and demonstrating the presence of viral antigens in RNA. And an interesting paper that showed that dogs that are trained to detect SARS-CoV-2 infected supernatants are able to identify 50% of long haulers, whereas 0% of the controls were identified by such dogs, indicating that there must be volatile compounds that are released from such viral reservoirs that may be sensed by the dogs. The next hypothesis is autoimmunity. There is a very nice paper by Jim Heath's group that demonstrated lupus-related autoantibodies at the time of acute COVID to be one of the 4 predictive factors for long COVID. Papers that have looked at later time points, however, including our own preprint, has not really identified autoantibodies that are associated particularly with long COVID disease. The third hypothesis is dysbiosis of microbiome and or reactivation of latent viruses that include herpes virus family members such as Epstein-Barr virus. There are now 3 or 4 papers coming out that demonstrate the reactivation of these latent viruses, preferentially in long COVID patients. And we and others have also been looking at impact of distal inflammation, such as respiratory infections, impacting distal organs such as the central nervous system. And this was demonstrated with Michel Manger's group that distal inflammation can have a long-term consequence on the cells within the CNS, resulting in chemo fog-like syndrome, which involve demyelination of axons of neurons within the white matter of animals and in human patient samples. So the study that I'd like to highlight today is a collaboration that's done with Dr. David Petrino's group at Mount Sinai School of Medicine, along with his colleagues, Jamie, Laura, and Dana, that are pictured here. We have been in collaboration for the last two and a half years or so, really trying to understand the mechanism that underlying long COVID, particularly studying the immune responses. And these 6 first authors of this paper have done a remarkable job of looking at so many different aspects of the immune responses that are distinct in long COVID patients, which I'd like to share with you today. So the study was to look at the immune signatures in people who've had COVID over a year ago. So this is a much later time point than most studies that have been done to date. We're looking at electronic medical records, symptom survey, flow cytometry to look at activation and composition of cell types, looking at antibody reactivity to human exoproteome, which are expressed on the surface of cells as well as secreted proteins. We've also been looking at antibodies against SARS-CoV-2 antigens, peptide display library to look at linear epitope that are recognized by people with long COVID, plasma proteomics, and hormone analyses. We've recruited 4 sets of patients or participants. The long COVID patients are in purple. The convalescent control are in yellow. These are the people who acquired acute COVID around the same time but have fully recovered. Healthy control in orange are the people who've never been infected with COVID. And the healthcare workers in blue, these are the participants that donated blood for serology analysis against SARS-CoV-2 antigens. The comparison of the long COVID participants versus the convalescent control in yellow show that the age, sex, and acute severity of COVID were as well matched as we could possibly obtain. With the age group being around 45, 40 years of age, and sex female dominated. This is typical of all long COVID studies. This is a female dominant disease. And we focus on people who were not hospitalized. So vast majority of the people in long COVID and convalescent control groups were not hospitalized. We also looked at days from acute COVID, and you can see that they're average around 400 days or so. Again, there was no significant difference between these two groups. I'm only going to highlight the key features that were distinct between long COVID versus non-long COVID groups. The first thing we noticed are that the composition of circulating blood cells are distinct. For instance, the long COVID participants had elevated levels of non-conventional monocytes, as well as reduction in circulating conventional dendritic cell type 1, and elevated activated B cells, as well as double negative B cells. We also saw a reduction in circulating central memory CD4 T cells, as well as elevation in exhausted T cells. And while we do not understand what these exhausted T cells are recognizing, this is a sign of a chronic antigen stimulation of CD8s and CD4s, potentially driven by the persistent virus, but it could be something else. Okay. Next, we looked at the ability of the T cells to secrete different cytokines. And what we detect here is that the CD4 T cells, for instance, from long COVID patients had elevated levels of IL-2, IL-4, and IL-6. And these are cytokines that are normally kept at bay, but the long haulers, as you can see, some of them have quite elevated levels of these cytokines from the CD4 T cells. And what's interesting is that the IL-4, IL-6 double positive CD4 T cells are almost uniquely found only in the long COVID patients. And I'm going to tell you what these cells might be correlating with a little bit later on. Looking at the antibody analyses against SARS-CoV-2 antigens, we see that there is elevated levels of anti-spike antibodies in long COVID patients, accounting for the numbers of vaccines that they've received. So all the serology here shown are people that have received 2 doses of mRNA vaccines. And then you can see that the healthy control and the convalescent controls, they all have obviously anti-S antibody, but the level in long COVID patients were higher than the control groups. We next examine the different types of circulating hormones and proteins that are distinct in long COVID patients. And what we found in the upper left panel is that the cortisol level was the most significantly different between the 3 groups, particularly in long COVID versus non-long COVID. You can see on the bottom left that the long COVID participants had about half of the cortisol level in circulation compared to healthy control. And normally, cortisol is tightly regulated from the hypothalamus pituitary adrenal axis. And normally, when you have a lower level cortisol, you would expect a higher level of the ACTH that's secreted. Somehow there's another slide that came on. Can you put my slide back, please? Oh. Okay. So as I was saying, the ACTH level is expected to be elevated when there's low levels of cortisol. But what we see is that that level was not elevated, suggesting that there may be hypothalamus or pituitary defect in long COVID patients that's not regulating the level of cortisol appropriately. And then we looked at the time of collection to make sure that the time during the day of blood collection was similar between the three groups, because cortisol, as you know, is a diurnal hormone, and it is elevated maximally during the morning, and then it gets the level goes down during the day. But we did control for the time of collection, and that was not significantly different. So looking at other factors like latent virus reactivation, what we see is that using the rapid extracellular antigen profiling that was developed by Dr. Aaron Ring's laboratory, we detect elevated levels of IgG against Epstein-Barr virus, GP42, as well as P23 and early antigen diffuse. We also detected elevated levels of anti-VZV-GE, and that may also be reactivating in the long COVID patients over non-long COVID patients. Looking at this, we actually tested the level of anti-EBV antibody in 3 different orthogonal methods. One is using the REAP, the other one is using the linear epitope mapping by Serimmune, and we detected a particular peptide within the GP42 that's highlighted in pink on the right figure, and that was elevated in the long COVID participants compared to the others. And as I was saying before, the IL-4, IL-6 double positive CD4 levels are correlating with the GP42 or GP23 specific antibody levels in a positive correlation, potentially indicating that these antibodies are elevated in these patients because of reactivation of EBV, and that may be affecting the ability of T cells to become Th1 cells. It's well known that EBV interferes with the development of Th1 cells in order to preserve the latency and reactivation. What about autoimmunity? We've looked at autoantibody levels during the acute severe COVID and found a diverse functional autoantibodies at that point. However, looking at long COVID patients, we did not see significantly different levels or the numbers of autoantibody reactivity against human exoproteins, suggesting that they might not be playing much of a role during at least this late phase of long COVID. Using the thousands of data set that we collected from long COVID and non-long COVID participants, we applied machine learning algorithm to analyze whether immune features alone can distinguish people with long COVID. And indeed, it was able to do so with 96% accuracy. When we looked at the various different factors that contributed to this prediction, autoantibodies had the least contribution, whereas antibody against the COVID proteins, as well as EBV and cytokines and the flow cytometry features really contributed to the ability of our ability to predict long COVID from just looking at the immune features. Looking at the overall features that are associated either negatively or positively with long COVID, we see that the cortisol level is again the most significant feature that's lower in long COVID patients, along with things like circulating central memory cells. Whereas what's higher in long COVID appears to be the activated B cells, EBV reactive antibodies, and the exhausted CD4s and CD8s. So taking all this into consideration, as well as many other studies that have been published to date, What we think now is that the viral reservoir hypothesis is certainly one of the most likely scenario what's happening in long COVID, because of the fact that we're seeing this sort of continuously elevating levels of antibodies, and there are numerous reports demonstrating antigens as well as RNA in multiple different organs months after the acute phase of COVID. We also think that the reactivation of latent viruses such as EBV may be contributing to the disease. Now, none of these features, we don't know right now whether they're driving the disease or they're just a biomarker of having long COVID, but that's something that we'd like to figure out with further studies. Autoimmunity, as far as exoproteome reactive autoantibodies are concerned, we don't see a significant feature in our own studies, but obviously there may be T cells or other types of antibodies that are involved. And tissue damage is something that is becoming more and more clear from many other studies. We did not deal with that in this particular preprint. So I'd like to thank all the people that were involved in the data that I was able to present to you today. Many of the first authorships I have already been able to highlight, but David Petrino is an equal contributor to the study that I was able to present today, as well as we have other studies that are ongoing, such as the Yale Listen study that we are carrying out with Dr. Harlan Krumholtz's group, and the immune profiling and data analysis team at Yale, Aaron Ring, Ruslan Mezitov, David Van Dyke, Wade Schultz, and Seramun team are absolutely critical part of the study that I was able to present today. So thank you so much for your attention.
Great. Thank you so much, Akiko. That was really fascinating and great to hear from you, the latest research that you've been doing. We now have Dr. Elizabeth Whittaker. She's the Honorary Clinical Senior Lecturer in Pediatric Infectious Diseases and Immunology at Imperial College London, and also the Pediatric Infectious Diseases and Immunology Consultant at St. Mary's Hospital in London. So welcome, and looking forward to your talk, Elizabeth. Elizabeth, can you hear us at all? Apologies. It seems like we have some technical difficulties. So, yes, really sorry about that. But we'll try to.
Can you hear me now?
Yes, we can. We can hear you now.
Are those my slides that you can see?
Yes.
Yes. Great.
Yes.
Thank you so much. And apologies for the glitches. And they're moving okay? Are they moving? Yes. Okay. So I'm a pediatrician. I established and set up the long COVID services in London for children and young people under the age of 18. And I also am an immunologist and have worked on COVID over the last 3 years, and prior to that, tuberculosis. And really what I wanted to highlight in hopefully the next 10 to 12 minutes was just how different an experience children have had compared to adults. So this graph on the left is very different to what has been experienced by what we saw at the beginning of the pandemic, and which has held true from the very beginning, which is that children make up a teeny tiny proportion of those who are unwell or admitted to hospital, and thankfully who die due to COVID, because they respond very differently to this virus to those who are of adult age. And what you can see here in this very simple pie chart is that the vast majority of children experience asymptomatic or mild symptoms when they are infected with SARS-CoV-2, and a really tiny proportion either have moderate symptoms or end up in hospital. And then about 6 to 8 weeks to the peak of the pandemic, we started to notice this post-inflammatory condition called PIMS or MIS-C, which I'll talk about in more detail in a moment, which is a really profound inflammatory process that affects a very tiny proportion of children, but is probably quite important to understand in terms of what is the pathogenesis, what are the differences, what drives this immunopathology that we see in children as well as in adults. And of course, in addition to
So my apologies again for the technical difficulties. We seem to be kind of having a lot of problems all around today. We're trying to fix Dr. Whittaker's camera and mic, and if you could just stay with us for a minute or two, we'll try to fix that. And if not, we'll move to Professor Brookfeld's presentation if there's any issue. Oh, there we go.
There we go. Did you hear any of that? No. Harriet.
Yes, we did. We did hear
But it
much
just
of
dropped
it.
it when I was okay.
Yeah.
Where did I get to?
Okay, so
You can hear me okay?
yes, we can hear you
Okay.
perfectly.
I had just been explaining how children had a different presentation to adults, with mostly very mild infections, but obviously some interesting things that are worth exploring, both in the context of severity of disease, but also post-COVID syndrome or long COVID. And that's the kind of the other post-infectious sequelae known as PIMS or MIS-C. And what I was then just explaining, and I'm not going to go into detail, just particularly in the interest of time, is that children have very different immune responses to stimuli in early life anyway. And this is related to their ability to develop tolerance, to train their immune system, to protect them from infection, but also to protect them from having an excessive inflammatory response much of the time. And so we know that their immune responses in the mucosa in particular are quite different, but also their specific immune responses to infections are quite different. And this is probably related to the fact that they then manage to clear or manage the SARS-CoV-2 virus very differently when it enters the body, so that it's less likely to drive that profound inflammation that results in severe disease in adults. In addition, they have different numbers of receptors, but their cytokines and their T cell responses are really fundamental to this. And in addition, and this is also probably very relevant for long COVID, their endothelial cells, which are the cells that line your blood vessels, and their blood vessels are much healthier than in adults. And so adults, through lifestyle choices, including diet and smoking and just age, often have a little bit of underlying inflammation that's occurring in their vessels all the time. And when you introduce pro-inflammatory cytokines in response to an infection such as SARS-CoV-2, that can become excessive very quickly. Whereas in young children or young people, those endothelial cells are in a much better condition. And that probably explains as well some of the reason why adults are much more likely to experience severe disease. And not all children avoided severe disease and death. unfortunately. And it was really important that we understood why. And so we spent quite a bit of time exploring those children who were admitted to hospital and died due to SARS-CoV-2 in the first year of the pandemic, and in particular identified that there is a particular risk group, and actually what they're dying of is very different, or what makes them very sick is very different to what we see in adults. So they're not getting a hyperinflammatory immune response, but often they've got really complex underlying health needs, which means that the reserve is different. So actually they get very unwell with COVID, but they could equally become very unwell with influenza or any of the other viruses that circulate in the winter, rather than seeing a big proportion of young people who present with adult type disease, which is very uncommon. And so children have a very different spectrum of responses to the SARS-CoV-2 infection. And I've tried to put that pictorially here, that following infection, the vast majority of children experience really just asymptomatic or mild illness. We see a tiny proportion of severe disease, and sometimes adult type disease, particularly in obese adolescents, but actually just severe illness because of underlying comorbidity in other children. And then we start going down the spectrum of really interesting post-infectious inflammation, either alongside respiratory illness or more commonly 4 to 6 weeks later. And we describe this as multisystem inflammatory syndrome, as it's known in America, or pediatric inflammatory multisystem syndrome. And basically what that means is that your body is very inflamed and has an unusual response to the virus, becomes too inflamed and makes you quite unwell, particularly if it affects your heart. And I've put at the bottom here, we can't forget that proportion of children who develop a post-COVID condition, of which there are many different types. And I think that's something I'll explore in a moment. So in summary, this post-infectious sequelae, which occurs 4 to 6 weeks later, in actually a very small proportion of children, is very significant. These children are extremely unwell. About a third to 40% end up in intensive care with what we call shock, so that they're so unwell that their blood pressure drops and their heart's unable to sustain a good supply to the rest of the body. And they have a very distinct picture of inflammation in their blood, which is quite similar, interestingly, to what we see in severe disease in adults. But because it's a post-infectious phenomenon, they usually have developed antibodies already. It affects the gut predominantly, as well as the heart, but it's very multi-system throughout the body, with changes in the skin and significant rashes and red eyes. And this condition is probably the bit of COVID that's been explored from a research perspective most thoroughly in children. But actually, there's been a real paucity of research and funding for research in children to do with COVID, because, as I said at the beginning, they've made up such a tiny proportion of children. And that is problematic, because actually by studying the extreme ends of the spectrum of age, you can often get answers to all ages. And it's something that's a big problem for pediatrics. This is one very small study looking at follow-up of that cohort of children who've got that post-infectious inflammatory condition. And this is from Great Ormond Street in London, where I work. And it just shows you that this is a colour graph to show you how many different symptoms all the children had at presentation, how they improved dramatically over 6 weeks and then by 6 months. And actually all the things we'd worried about, which is whether they would have persistent heart problems, were very reassuringly normal. But interestingly, these children do develop persistent gastro symptoms with mild CNS abnormalities, headaches, fatigue, all things that are very familiar to people who see children with long COVID. And it really begs the question as to whether or not long COVID in children is related to MIS-C or PIMS in children. This is just a picture from some of our other slide presentations, which will be very familiar to anyone who's been studying long COVID. It causes a myriad of symptoms which affect literally every body part, multi-system, as you might say. And I guess the question is, how common is long COVID in children? So this is data from the Office of National Statistics in the UK, looking at symptoms at 12 weeks and 12 months by age. And again, what we can see is that although these numbers are not to be dismissed, they are much lower in children and young people than they are in older adults, and that children and young people are also more likely to improve or have resolution of those persistent symptoms over time. It's actually very difficult to get a handle on how big a problem it is, because there's a lot of difference in how people measure symptoms, and it's often self-reported, and there's a real paucity of control groups. So it's very difficult to tell whether or not this is just something that's happened as a result of the lockdown, or whether this is actually virally mediated. the clock study, which I'm a co-investigator on, went out of its way to try and include a control group of children who didn't have SARS-CoV-2 infection and found quite a high prevalence of persistent symptoms. But interestingly, they found that in those children who didn't have a SARS-CoV-2 infection either. And so
Excuse me, Elizabeth, would you like us to move to one of your slides? Because we just noticed that they're not moving ahead. So if you tell us what number it is, we can just move it.
I'm so sorry. Yeah, I think it's because, yeah, could you go to, I'm sorry about that, slide number 10?
Sure.
Are those, I think those are my slides. You want me to unshare and go to the other set? I'm so sorry, everybody, that we're having technical issues.
You can just, if you want,
pandemic, you think we'd be professionals at this, right?
If you'd like, you can just say next slide.
Yeah, and I'll say next slide. I think there might be an issue with this in terms of animation, so I apologize that if the slides don't come across as beautifully. So this is just the prevalence from a systematic review showing you that this little dot here, I hope this is bigger for everybody else, is the clock study. But interestingly, although there were more persistent symptoms in children who had a positive SARS-CoV-2 infection, there was a very high rate of persistent symptoms in those who didn't. And what's different about those children who'd had a positive infection is that they're much more likely to experience multiple symptoms, both at the time of infection initially, but also persisting. And are there predisposing factors? I think every parent wants to know this, is what do I need to worry about? And I think that's unhelpful is that the vast majority of these children and young people were completely healthy prior to developing persistent symptoms, but that some particular groups of infections, which such as allergies and respiratory illness, previous chronic fatigue, and then some neurodevelopmental diagnoses such as tics and obsessive compulsive disorder and even autism are more commonly seen in those children who experience persistent symptoms. And there's lots of theories about why that is. Is it because as a group of young people, are they more in tune or more sensitive to symptoms that they're experiencing, but also have they challenges in terms of their emotional and mental well-being to help to self-manage those symptoms, which makes them become overwhelming very quickly. And what's really interesting is that there's also a family history component to the children and young people who present with persistent symptoms. Next slide, please. And this is just a very brief look at that in our clock study, just showing that those children who had persistent symptoms were nearly twice as likely to have parents with persistent symptoms than those who didn't have them. And this was independent of all the things that we could correct for. And it's really interesting when we're trying to understand the pathogenesis of the condition to think about why that might be. Is it because they've had a different exposure to the virus, like a much bigger viral load? Are there genetic factors that made them all predisposed to an autoimmunity, as Akiko mentioned, or perhaps something like that? Is there bias so that the parent who's got symptoms is more likely to encourage their child to take part in a research study? And so that kind of desire to help because you are also affected. Or are there psychosocial factors within the family that again make it difficult to manage symptoms that might be more persistent? But I think what came out of this is the adult and children's services are run very separately from each other, but there may well be a need for family clinics in order to provide better care for these families for whom both the children and parents are experiencing persistent symptoms. And that's something we're trying to work towards in London. Next slide, please. So this is slightly ruined. I had a slide explaining the range of patients that we see in the long COVID service for children and young people in London, and it's really diverse. We see functional gastrointestinal disorders, we see rashes and mast cell dysfunction, we see desaturation with poor perfusion, we see a lot, and the vast majority of what we see is chronic fatigue-like syndromes with headaches and really quite exceptional fatigue and difficulties with getting around. We see a lot of dysfunctional breathing and dysautonomia. But I wanted to make the point is that that's not new to anyone who's been reading about this topic. But what worries me is they all fall under the umbrella of long COVID. And this has two challenges. One is there ever going to be a single diagnostic test if we're describing a group of different conditions? But also there is unlikely to be a one-size-fits-all treatment for this. And we have to be really cautious when we talk about this condition to remember that it's probably multiple different conditions, and they do need careful phenotyping, both to try and understand what's causing them as well as what might make them better. Next slide, please. And again, this is basically what I had done at the bottom of that slide I showed you before, although maybe you missed it, was I was talking about the spectrum of illness after SARS-CoV-2 infection. And I still think the vast majority of children and young people experience mild or asymptomatic infection with no sequelae. However, we do see significant post-inflammatory conditions in terms of MIS-C and PIMS, but we're also recognizing multiple different conditions from a post-COVID perspective and long COVID, and different clusters of types of conditions that children and young people present with. And what we don't know is, and you've heard a really lovely talk about the different types of causes of these conditions, whether there are endothelial problems, platelet dysfunction, whether there are autoantibodies, whether it's due to gut viral persistence. And again, what it's really not explaining to me is whether we're actually doing a disservice to each of these conditions by giving them one name, but also what I don't understand when there's this clearly mapped out difference after SARS-CoV-2 infection, why it's so hard to get funding for this condition for research in children and young people. We've written multiple grants, which we've really struggled to get funding for, and I recognize that children are a smaller group, but actually it's really important to get it right in early life. Next slide, please. So this very briefly is the area that has managed to get good research funding is that very inflammatory post-infectious condition, MIS-C or PIMS that I described. And what's really interesting, and this is a very busy slide, but the main message really is that the pathogenesis and the hypotheses are not dissimilar to those that were described earlier by Akiko. So we think that viral persistence may play a role, particularly in the gut. We don't know if autoantibodies may also be quite important. And the superantigen hypothesis seems to be gaining less traction at the moment. There's some lovely data from the US that's coming out about the viral persistence driving something else. But actually we see a lot of herpes reactivation as well in this cohort because they've lost immune control when they're very pro-inflammatory. Next slide, please. And I think what we need to do is try and get the same amount of resource and research into other post-COVID sequelae that are affecting children and young people. Next slide, please. Has it just fallen off? I was going to talk about the fact that what we're doing in our setting, both working with colleagues in the US with the NIH-funded PREVAIL study, but also the DIAMOND study, which is a European study, and this is not specifically funded for long COVID, but because of the senior investigators on the group have agreed to include both children and adults with post-COVID, as well as people who don't have chronic fatigue for other reasons. And what we're trying to understand is there a diagnostic signature that we can develop to pick out this group? As I've already mentioned, this would need to be a very well phenotyped group so that we could understand exactly what each cluster would look like from a diagnostic perspective. But we'd also be able to compare it to different types of COVID, so mild disease, severe disease, as well as those post-inflammatory sequelae I talked about. And we would then be able to understand whether this is in the same spectrum or whether there's a very different condition going on for post-COVID syndrome. Next slide, please. And I know that Judith is going to talk about this in a moment, but the reality and the expectation of management of post-COVID syndrome is that they do not meet each other. I think that because this is such a debilitating condition and people are without hope, they come to a service and think that there's going to be some kind of magic fix. But actually, we have very little to offer because we don't yet understand the pathogenesis, and therefore being able to give specific treatments is very challenging. Next slide, please. And again, this slide was showing you some of the treatments that are available either in research studies for adults or that some people are using without evidence. And that includes things like anticoagulation therapy, in particular heparin, steroids, hyperbaric oxygen, amongst others. And again, I bring back to this point that long COVID is an umbrella term for multiple conditions. And there is no evidence in children to support what the pathogenesis is or whether any of these treatments, which all have side effects, could potentially cause harm. And so it's really crucial that we get funding to do appropriate studies to look at outcomes from treatment rather than treating empirically, because the benefit risk is not clear at this time. Next slide, please. And this is just a slide of a table showing that we have to be really cautious all the time in pediatrics to remember that actually it's okay to extrapolate from adults if we are confident that the conditions are the same, but it's very dangerous to extrapolate from adults if we don't think the conditions are the same. And I think that we've seen so far in the pandemic that children have a very different response to SARS-CoV-2 virus, both in terms of the acute illness, but also the sequelae. We very rarely see MIS-C in adults. It is very much a pediatric condition, and we have to be cautious to understand whether post-COVID or long COVID is the same in adults and children before we start using treatments that might have some value in adults but may be detrimental in children. And next slide, please. I think that's my last slide. So just to summarize, there is a massive clinical overlap in persistent symptoms after MIS-C and long COVID. And we have seen some really similar hypotheses, but we have to be really cautious about how we extrapolate from adult data for long COVID. And really, one of the biggest challenges is getting funding to do pathogenesis studies in children to understand the condition, but also to make sure that we use the right treatments for these kids. And there are many people on my next slide that I need to thank, but I'm going to end quickly because otherwise we'll run out of time for discussion. Thank you, yours. Thank you.
Great. Thank you so much, Elizabeth. That was really interesting. And I found it really interesting what you said about the fact that we can't necessarily do the same treatments that we know of for adults, for children. So I thought that was really interesting to know. So now we're moving on to Judith, Judith Brookfield, who is the professor of infectious diseases at Karolinska Institute and the senior consultant in infectious diseases at Karolinska University Hospital. So I'm very much looking forward to hearing what you have to say, Judith. Thank you. Bye.
Thank you. I just wonder, can I have the slide a little bit larger, or is that the maximum?
So for the audience, they'll be seeing the slide in a large scale, but
okay. But
yep.
For me, it's like that. Okay.
Yes. Yeah.
Okay. Fine. No problem. So thank you very much for the introduction, and I can move my slides, I hope. Yes. So I'm going to talk about patient care and also optimum trials. I agree perfectly with Elizabeth regarding the problems also with treatment in adults. This is just to introduce you to key members of our post-COVID-19 team, which we actually organized almost 3 years ago. So it's myself, Mick Adriano, who is a very experienced chest physician, Marcus Ståhlberg, cardiologist, and also Malin Nygren-Bonnier, who is a physiotherapist and leading the health professional research project that is very closely integrated with our own research project. So regarding acute COVID-19, we understood from very fast, actually, that there was a potential for long-term sequelae from what we saw in the acute phase. And we knew also quite quickly that SARS-CoV-2, the virus, enters cells via the special receptor, AC2 receptor, and these receptors are represented in multiple organs. And so it was not really a surprise that we would see long-term sequelae. And this was also our hypothesis when we started our follow-up clinic. Let's see. Yeah. So long COVID, as Elizabeth pointed out, is an umbrella, a syndrome which contains various phenotypes, at least from what we've seen in the adult cohorts. The long COVID patient is typically multisymptomatic, and that is why this is a challenge for healthcare professionals, because we are okay. It's something. Thank you. If you press full on the upper right-hand corner. Aha. Okay. Great. Oh, fantastic. Okay. So anyway, this was a challenge for us. We are organ specialists, maybe not an infectious disease doctor. We look at the whole body. But anyway, this was difficult for us. And Actually, I borrowed the fridge magnet that I got from my children for Christmas in 2020, where I say in the Swedish radio news that we know essentially nothing at all of what will be long-term problems. And at you can see at the top, no, we know nothing. And my children thought that was very funny that I said that. But it was true. Fortunately, regarding trials and studies, there were several very large registry studies of long-term effects initially in the pandemic, and that was important because this was very much discussed, not the least in Sweden, but I know also in a global perspective. Is there something called long COVID, or is it something that the patients are sort of imagining? But several large studies comparing hospitalized versus non-hospitalized COVID-19 patients, and also comparing long-term sequelae to influenza and other respiratory infections, showed an increased risk, as you can see here, for both psychiatric diagnoses, dementia, sleep disorders, stress, respiratory complications, and so forth. And Ziad Al-Ali is a very good both colleague and researcher, and he has analyzed the U.S. Veteran Affairs Registry from many angles. He's a nephrologist, and therefore they also looked at kidney function over time. So in the top of the figure, you can see the normal aging of the kidneys. And then you see various lines where non-hospitalized patients with COVID-19, their kidneys age faster than they should, even more so in hospitalized patients without acute kidney injury. And the worst outcome is for hospitalized patients with acute kidney injury and dialysis during their hospitalization. And this is a very important finding because this is a silent long-term effect. We normally wouldn't check kidney function in, for example, non-hospitalized patients over time. Numerous studies, very large cohorts, have shown also an increased risk of both type 1 and type 2 diabetes after COVID-19, possibly as a direct injury to the pancreas. Also, again, Ziad Al-Ali and his group have shown that with additional COVID-19 reinfection, there is an increased risk of long-term sequelae. And this is important, of course, regarding prevention with the vaccination. Another important finding, and this is a preprint also from the same Veteran Affairs Registry, shows that antiviral treatment in the initial phase, acute phase of COVID-19 with Paxlovid significantly reduces the risk of 10 out of 12 long-term sequelae, post-acute hospital care, and also death. And this reduction was seen both in vaccinated, unvaccinated, de novo infection, and reinfection. So this is very important regarding, and also may point to the fact that viral persistence may be a player in this, in the long COVID syndrome. Okay. Some studies also regarding follow-up. These are not registry studies, it's prospective follow-up studies, similar to our own studies, where up to a 2-year follow-up of from Wuhan, the epicentrum of the pandemic, showed that survivors with long COVID symptoms at 2 years had lower health-related quality of life, worse exercise capacity, more mental health abnormalities, and also increased healthcare use after discharge than survivors without long COVID symptoms and controls. But you can see that this was not a very sick cohort. 1% required mechanical ventilation during their hospitalization. In the UK, there was a 12-month follow-up of about 800 hospitalized patients. And here about 1/3 were on initial mechanical ventilation. And here you can see that the risk factors for poor recovery was female sex. And this has been consistently shown in adult cohorts that female sex is a risk factor for development of long COVID. Also, obesity and mechanical ventilation were risk factors. And here you also can see that the proportion with full recovery at 12 months was less than 30%. And when measuring the health-related quality of life, this was significantly lower at 5 and 12 months compared to before COVID-19, and with marginal improvement between follow-up time points. So, going to the next issue, ideal care pathways and research. From our perspective, I think this is crucial for both diagnostic and mechanistic rehabilitation trials. So I'm completely agree with Elizabeth that we should be very stringent and consistent when we go for treatment trials. In the Swedish national recommendation from 2021, it was decided, I think a bit early on, that primary care should take care of post-COVID patients, and there they should be assessed by multi-professional teams and then referred to post-COVID teams in secondary and tertiary centers. This was problematic because our knowledge was not good, not even in specialized care, and even less in primary care. But the Stockholm region has decided that assessment should include broad differential diagnostic workup and specific workup based on symptoms, and referral, a bit unfortunate, I think, possible to organ specialist or hospital-based post-COVID teams. And now more than 1.5 year old recommendations, national Swedish recommendations, said at that time, April 2021, that there should be a multidisciplinary, multi-professional post-COVID clinic available in every region. But from a report from this autumn 2022, only 12 out of 21 regions had a dedicated specialized post-COVID clinic with a varying organization, but now 3 of them have closed down, so we only have 9 specialized clinics. This is a recent review where the slide I showed you with all the symptoms, it was really an enigma from the start, but we have acquired some more knowledge regarding symptoms related to organ dysfunction, although we haven't reached complete understanding, but we know more today than what we did at the beginning. And now I will just take you briefly through our own experience with a multidisciplinary, multi-professional post-COVID clinic that we started with the first patient seen May 12, 2020. We had quite harsh criteria due to lack of resources. So hospitalized patients with severe COVID-19 pneumonia primarily were seen by us at the beginning. And then from summer 2020, we started to get referrals from the GPs where non-hospitalized patients did not recover as expected. And there we required symptoms more than 12 weeks and sick leave or the corresponding of 50% or more. And you can see here that we had a large number of medical disciplines and also diagnostic specialties, radiology, clinical physiology, intensive care as well, and also health professionals surrounding the patients. And we saw the patients together, and we have followed the patients, which I think is very important because otherwise you don't learn anything about the long-term progression, relapses, and so forth. And I don't know if anyone remembers the band, Blood, Sweat, and Tears. They are still performing, but this was really blood, sweat, and tears for all of us, both healthcare and the patients. But we learned together, and we know much more now. I'm just keeping a bit track of time here. So our research project were linked to this follow-up. And here we wanted to evaluate long-term effects in patients of these 2 cohorts. We have conducted in-depth phenotyping of patients, and we are now linking these to in-depth immune response studies for which Professor Petter Brodin at KI and Imperial College is responsible. We are assessing the patients for research purposes annually up to 5 years after initial disease, but we are also following patients that have not recovered in our own setting. And we also evaluate rehabilitation interventions. So as you can see here, I won't go through the details, but we do have done a very thorough medical examination, lots of radiology, clinical physiology, blood sampling, and biobanking, and as you can see here, a number of physical tests and questionnaires. Oh, what happened now? No. Now I did something wrong, I think. Just a moment. Yeah, so this is just some brief results. We have 2 different cohorts then, almost 500, I think more than 500 patients in each arm now. And as you can see here, regarding what Elizabeth said, that this is a syndrome containing different phenotypes. The hospitalized patients, the majority are male with comorbidities such as high blood pressure, diabetes. They are also obese, as you can see, with BMI 30, median age 57 years. And this was during the first wave, a hospital stay of 22 days. And you can see that about 75% were cared for in the ICU. The non-hospitalized cohort is completely different regarding gender, majority female, previously healthy, younger, median age 45 years, normal weight, and often physically active. They share some common symptoms in both groups, as you can see, but we find different things, and I will show you that in just a little while. This is a long-term 20 months follow-up in non-hospitalized patients. This was an abstract in the European Respiratory Society conference and also a national conference. 51 patients, 92% women. Time to first visit, which is important, mean 9 months. It's a long, very long delay for very sick patients to come to specialized care. And here you can see that 47% were on full-time sick leave at baseline and 33% at follow-up. You can see that the patients improve in some aspects, but the health-related quality of life, which I have circled, you can see that it's very low, 34 out of 100, which is perfect health, and 39 at follow-up 20 months, which is a terrible situation for the patients. Regarding pulmonary sequelae, very briefly, I can say that on the upper radiograph here, you can see that, I don't know if my arrows is there, but anyway, you can see that there are some subpleural residual lesions. This we see mainly in the hospitalized cohort. Is this a fibrosis that is ongoing? Will it develop over time? That is one research question. We also see this phenomenon air trapping, where you see darker areas in the lungs on maximal expiration. And here we did, for a period, dual energy CT, where we could see, or at least expect some areas with impaired perfusion. And here, this is a recently published study based on our findings, where dynamic contrast enhanced magnetic resonance imaging has been performed. And here you see on the left a healthy control, and on the right a post-COVID patient. And here time to peak perfusion is impaired in the post-COVID patient. So there is something going on in the vascular system here. It's not entirely ventilatory. Okay, and regarding cardiovascular phenotypes in the hospitalized patient group, more of the typical cardiovascular phenotypes linked to, for example, obesity, diabetes with coronary disease, myocarditis, but also endothelial dysfunction, which is something we also see in the non-hospitalized group, and this is persistent over time. We also see a lot of dysautonomia in the non-hospitalized female group, POTS, for example, and also microvascular dysfunction. And here you can see in the bottom microvascular dysfunction imaging with stress perfusion heart MRI, where we give adenosine, which makes the heart beat faster. And you can see that the left is a healthy control with perfusion of the left ventricle. It's yellow, that is perfect. But on the right, in the right image, you can see this is a POTS patient with long COVID. You can see that it's really not well perfused here. And this is, it's more bluish. And this is also a reason for angina, actually, in these young females. And this is evidence for end organ effect on endothelial function. This is also very brief. We have analyzed 365 non-hospitalized PAX participants, 3 subgroups, PAX with POTS, PAX who did not fulfill POTS criteria when they were investigated, and the third one not assessed for POTS. And prevalence in this cohort was approximately 1/3 of the total cohort. And although all groups underperformed, participants with POTS were significantly younger, females had a lower health-related quality of life and physical activity post-score, faster heart rate after sit-to-stand and 6-minute walking test, and also lower 6-minute walking test distance. Yes, this is also from this review that I showed before, and this is just to emphasize what Elizabeth said regarding treatment studies. That the evidence for treatment studies is quite low, and therefore we have to be careful. And just some examples from our own interventions and treatment studies. For microvascular dysfunction, enhanced external counterpulsation has been used with some effect. There's an ongoing feasibility study of individual tailored physical training for patients with POTS for 12 weeks, which shows promising results. Also an ongoing study of inspiratory muscle training, hyperbaric oxygen therapy for long COVID, which is a randomized controlled trial. We are now also organizing and planning for a randomized controlled treatment trial with Paxlovid, 15 days versus placebo, and we hope to start patient recruitment in April this spring. And then other possible treatment agents could be, for example, immunomodulatory agents based on immunopathogenic versus phenotypic study results, but there we need more information. So to summarize, this is long COVID is a new infectious disease with long-term effects, and we need to characterize and research underlying pathology to identify treatment targets. We think that it is very important with centralized, multidisciplinary, multi-professional post-COVID teams, both for diagnosis, treatment, and patient-integrated research and treatment studies. We have to extend investigation if we find pathology, and we also have to invent the bike while we are cycling, which is a bit difficult, but also interesting. Individualized rehabilitation is very important, and treatment studies should be hypothesis and diagnosis driven. And prevention, not the least, is important. Vaccination and possibly also Paxlovid for all if you are reinfected. So thank you very much.
Great. Thank you so much, Judith. That was fascinating. Okay, well, we're running short on time. We have about 15 minutes left, and a number of fascinating questions from audience members across the diverse spectrum of backgrounds, including leading immunologists, medical practitioners, students, patients of long COVID, organizers of long COVID community groups, and those who are simply interested in learning more about this topic. So let's go right into the questions. The first question that we have is from Natalie. And so we'd like to feature her on stage if she's here, Natalie, to ask your question. And for the audience members and speakers also, if you'd like to see the questions that are coming up, we'll post the first 3 on the Q&A tab on the upper right-hand corner of your screen, just so you can kind of preview what questions are coming up. But hopefully Natalie is here.
I am here. Can you hear me?
Yes, we can hear you.
Okay, I don't know if you've published my question. I have hit the published link.
Yeah, it's up, it's here, so we can all see it. But if you could ask it, that would be really great.
Okay, thank you. So I'm here from the charity Long COVID Support. My question is, are there differences in the immune response of men and women to the SARS-CoV-2 virus?
And I'll let you speakers just jump in wherever you feel like you would.
Can
like
you
to
repeat
answer.
the question? I couldn't hear it.
Yeah, are there differences
Neither.
in the immune response of men and women to the SARS-CoV-2 virus?
Yes, Natalie, maybe I can take that question. I cannot see my picture anymore, but hopefully you can still hear me.
I can hear you.
Okay, wonderful. Yeah, so we've studied sex differences in immune response during acute and long COVID. During acute COVID, what we found was that women tended to make better activating T cell responses compared to male patients. And especially as male patients aged, their ability to stimulate T cells became less and less. And that correlated with the worsening of their acute symptoms. In long COVID, we haven't even put this on the meta-archive yet, but we're preparing to do so. We're seeing similar differences in male and female patients, their immune responses in long COVID patients. And here, for example, the EBV reactivation that I showed you today, that is occurring more in women than in men. And also the cytokine secreting T cell feature, that's also more dominant in women over men. And whereas male long COVID patients appear to make more inflammatory cytokine responses. So it's kind of mirroring what we saw during the acute severe COVID phase, but a different flavor.
Okay, thank you.
Thank you.
Great. Okay, so we have our next question up from Petra. Petra, if you wouldn't mind just very briefly introducing yourself and asking your question.
Thank you, Harriet. Can you hear me?
Yes.
Hear my sound
Yeah.
and see my picture in the camera. Yes, I'm Petra Mois from Indonesia. I'm a mother of 2 daughters and a public health magister student here. And I also active in COVID Survivor Indonesia, a community-based organization that from people with long COVID, and also a member of ACTA-GCCB, the Global Community Commission Board. I would like, what I want to ask in this event is, how might we distinguish long COVID in children or teenagers from other normal developmental changes, such as change of mood, forgetfulness, restless, and etc.? Because I experienced to see my kids at 1 year after the infection, they show some difference from before, especially about memories, mood, and sleep disorders. And so how we can distinguish that from just a touch of a change of hormone in teenagers. Thank you.
Elizabeth, would you like to answer that question? Elizabeth, are you able to hear us?
Can you, I'm just joined on my phone because, can you hear me?
Yes, we can hear you now.
So, I mean, I think this is one of the things that probably is highlighted by the clock study, which is that you see a large proportion of children and young people who experience unusual persistent symptoms, even if they haven't had a SARS-CoV-2 PCR positive. So I think teenagers are going through a lot and they will have fatigue and things like that. But the young people that we see in clinic are really debilitated by this in a way that I wouldn't expect a normal teenager to be. That it's a fatigue beyond being a kind of Kevin teenager. I can't get off the sofa. I'm a bit tired. They can't even go and socialize with their friends. So I think it's the functional impact of the symptoms that probably helps in that understanding that this is beyond normal. And I think the other thing that's also really important to remember, and Akiko mentioned this at the beginning of her talk, is that actually having persistent symptoms after any infection is very well described. But normally we'd expect that to resolve within about 3 to 4 weeks, which is why many of the definitions start talking about long COVID after that time period. And so I think that the changes that you might experience with hormones, again, I would expect to resolve within a short amount of time, and that there would be relapses and remitting in a way that I wouldn't expect rapid improvements in a young person with severe long COVID.
Okay, great. Thank you, Elizabeth. Okay, and our next question is from Yassir, who is a college student in the UK, and I'll be asking for him. And his question is there a possibility of a complete recovery? And I'll leave that open to the floor.
I'm happy to. We've definitely seen a complete recovery in some of the children and young people. But if anybody has ever worked in the field of chronic fatigue or my ME before, which I don't speak for anyone, we know that actually children and young people are more likely to make a complete recovery than older adults, and are more likely to make even a partial recovery probably than older adults. So I think it is reassuring that we have seen that in our clinical experience. We're just pulling that paper together to publish, but we've been able to discharge a proportion up to 40% of our patients within a reasonable time frame. However, there are some, particularly those who started developing symptoms in 2020, who are still extremely debilitated. So there is a massive spectrum, and it comes back to that umbrella term. So yes, we've seen complete recovery, and I need Judith to talk about the adults.
Yeah, no, but we see, I mean, we see also recovery, but what is very typical and what we've seen is the relapsing nature of post-COVID. Yeah, so it's sort of relapses can go on for multiple months. Also, new infections which cause worsening of symptoms. So this is a very difficult situation. I would also, I've looked at the chat. I would like to say that we have been very much involved with the patients in our own follow-up clinic, both the patient organization and also Doctors for Doctors with long COVID. So we've learned a lot from the patients, and we have actually managed to solve at least some of the phenotypes with their help. So we are very grateful for that. And I can just apologize for the lack of interest in healthcare. I think this is a new disease that needs to be handled with adequate resources. And we've tried our best here, but it's quite difficult to reach authorities that have the funding, both for research, but that has been easier for research here than the organization of healthcare.
Okay, thank you, Judith and Elizabeth. So for our next question, it's from Alex, and he's here to join us. So Alex, would you like to ask your question?
Hello, can you hear me?
Yes.
Thank you for the great presentation. It's been very interesting, and there's a lot of new things that we've learned, well, I've learned from looking at it. I'm a medical doctor from South Africa, and also been suffering with long COVID for the past about 2 and somewhat years, with quite a bit of recovery in the 12 months. I'm so very interested in this topic on a professional as well as personal level. My original question, I think, has been answered a bit by some of the speakers already. It's around the top hypotheses. as well as good resources or data points for us to look at or review, but maybe to expand on that, because there is one hypothesis that I've been that I've been aware of, and I think some of the members of the audience has also raised, and it's the hypothesis around the persistent hypercoagulation. I think that was fairly popular in some of the South African medical doctors. Maybe the presenters can have comments about that hypothesis and what their thoughts are on that, and maybe other ones, or as well as resources that they could find useful. Thank you very much.
Thank you, Alex. Maybe I can jump in. So yes, so the major hypotheses that I described are all sort of potential root causes of disease. But downstream of that root causes, there are many other dysfunction that can happen, one of which is hypercoagulation. We actually are collaborating with Resia Pretorius's group, that whole team clot, to be able to analyze microclots and activated platelets. And so far, even though it's very preliminary, what we're seeing is that a lot of people with long COVID have these features. And so along with the low levels of cortisols that we described already, I think hypercoagulation is a major feature that is seen in many of the long COVID patients. What's driving that coagulation is currently unclear, but we should be thinking about treatment for multiple stages. Of course, if we can target the root cause, that would be great. But even if that's not possible, we can target potential pathologies such as hypercoagulation. And again, this should be done with randomized placebo-controlled clinical trials. But by doing so, I think we can be learning already about who responds well and who doesn't. And what do we learn about the biomarkers that are associated with a successful response? And I feel that the community should be moving towards doing well-designed clinical trials to be able to not just find a cure, because there will be multiple different drivers that's responsible, but learning from that process, what are the biomarkers of success, and can we recruit those patients for future trials? So that's sort of where I stand there.
Great. Okay. Well, thank you, everyone. I'm afraid we're really almost out of time. I wish we could go on for another half an hour. It's been just fascinating, and we have so many other good questions, probably close to 200 questions, and we'll hope to answer some of them, a small portion of them, in an editorial or blog later in the journal. But I wanted to thank you so much to the speakers for your fascinating discussion, and I hope in some way we can follow up on the pages of the journal. So thank you so much, and thank you to the audience for joining us.
Thank you.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.